So the title of this presentation is Incorporating People with Lived Experience into Clinical Practice. And we'll start by hearing with someone who has lived experience share about what their training was and how they got involved, what went well and what could be done better. And then you'll hear a narrative from me about what really made a difference. And then we'll share some general suggestions on what would help moving forward. JP, I'd be really interested if you could share a bit about how you got into your training, what it involved, and how you were able to graduate and complete that.
Sure. Well, I guess my training kind of started out as just something to kind of fill my time, to be honest with you. I think it was something that it was suggested by my caseworker at the time that this would be something good for me. Frankly, I didn't really think it would be something that was good for me. I was, still very deep into my substance use. And, to be honest, I had trouble navigating the most basic conversations, with, cashiers at Tim Hortons, let alone thinking I could be helpful to somebody else. So it was a bit of a long shot that I started this with. And, and it grew from there. So it turned out to be, I think one of the best developments of my life to be able to sort of take my substance use experience and flip that into an actual career was like, just sort of a dream almost, right? Like to think that I could do that and not a insignificant career either. I'm doing, very well for myself and I'm very proud of what I've accomplished. For some reason, I'm not able to hear you.
With the training program, did it involve courses, classes, on-the-ground activities?
Sure. Yeah, great question. So I think it depends on who does the training. But yeah, where I took the training, they had, I think it was 3 days a week, and they had different speakers that would come in every day. This is just kind of the first level of training. Then when you're through that, I think it was a 12-week program. They have like a practical placement, and my placement was to make a. I went to a housing center that was for serving our population, and I had to cook a brunch for 18 people with a $20 gift card, which was no small feat, but I think kind of what gives you the idea of what this program's a little bit about. And I did really well in it because I stuck in that program. I ended up keeping that placement for about 5 months because my colleagues who had been given this placement, when they got the gift card, the $20 gift card, you got a $20 gift card the night before. And they, they used that $20 gift card for their own needs. And they weren't able to go cook the breakfast because they spent the $20. And, I think that kind of tells you where people are at, right? And I was fortunate enough that I didn't need the $20 that badly that, I was able to go to work and do the job. But I think that kind of gives you an idea as to what, where these programs are, the baseline of these programs is at.
So you had about 3 days a week of courses, and then you had this placement that involved you cooking for people, and it was the consistency in both of those things that allowed you to graduate.
Yes. Yeah, absolutely. And that was kind of stage one of it, right? And then, so that was just with that one training program.
And what was it like when you moved from that environment into a hospital setting and you were onboarded as a staff of a hospital?
Well, there were lots of steps in between there. So I didn't go straight from that type of training to a hospital employment. So I went from there to the placement as I described, and then I volunteered also at a food bank. I volunteered at a food bank, and then I also took a job at a homeless shelter first. So there were all these little in between steps before I could even dream of working in a hospital, right? Because that's a gig that for people like me, that's a really unique and special opportunity.
What was really good about the experience of starting in the hospital and continuing in a hospital? And what could have been done better in the onboarding process?
Well, I think it's working in a hospital versus, I mean, it's just it's a whole nother kind of, you've got support, you've got security. I mean, I remember, the first job at the shelter, and nothing against the shelter, it was a wonderful, wonderful work. But I remember I got hit on my third day, like literally punched in the back of the head by one of the clients. And I didn't know how to react, and I didn't know how they would react. I didn't really know anything. I wasn't really trained that well as to what the policies were, but they asked that client to go for a walk for 15 minutes and come back. And that was the consequences for punching a staff member in the back of the head. And I'm not, I don't know where I really think about that, to be honest. If that happened in a hospital, you've got a lot more support. And that's a big difference.
So any gaps that might have been there in the hospital experience were much less than you would find in some of these community agencies. At the same time, these community agencies were more open to hiring people and directly involving people in clinical care.
Right. It's a totally different level of care that you're providing in a hospital versus in a community setting. The community setting, they really didn't care if you had lived experience or you didn't have lived experience. You're just there to do a job, right? You weren't hired because of your lived experience. The idea in a hospital setting, or we like to think the idea in a hospital setting, is that you're there because of your lived experience that you're bringing to the table. So it's a completely different kind of situation.
When you think to the onboarding at the hospital and the few years that you were there, was there any kind of thing that was missing, any support that would have been more helpful in terms of the process, either for you or some of the colleagues that you worked with?
Sure. Yeah, that's a great question. So I think the challenge is that you're taking people with, very recently lived experience and putting them into a, especially these days, putting them into a very stressful kind of clinical setting where our, most seasoned healthcare professionals, clinicians have trouble managing. So what would you think about throwing a recently unwell patient or recently well patient into that same setting? And so I think the idea is that you need to really build in the supports for those people. I mean, I've been very fortunate that I, was able to work pretty independently, but I think that's a testament to my previous work experience, but not necessarily what other folks are going to be experiencing. So I think it is key that you have the proper supports built in for people to debrief about their days. And this is not something an average nurse or an average pharmacist, you wouldn't build in an extra support for the pharmacist to be able to debrief at the end of the day, right? You just assume he's got his stuff together, that he or she's going to be able to do that. Well, and hopefully they do. But in the case of someone with lived experience, maybe not so much.
How were you able to work your way to getting a clinical position as a case manager? And what do you miss about being a peer support worker in that environment?
Well, you like, I think back to my own journey, right? It was a caseworker that changed my life. It was a caseworker's intervention that allowed me to put the pieces back together of my life. So in that way, it's something that I yearn to do. And I did a lot of, even as a peer. There are some gray lines between, or some fine lines in between these two roles. But I continued to do education. I continued to work in every placement I could. I worked in the inpatient unit. I worked in the withdrawal management service. I worked in any ED capacity I could. I worked in every different department in that building, and every opportunity that they gave me, or every overtime opportunity, I took it. So I think that might be, probably contributed a lot, as well as going back to university and taking addiction studies at McMaster, which was another, obviously a big component of me getting that placement. And
anything that you miss about being a peer support worker? as opposed to be now where you're more of a caseworker? That's your official title.
Paperwork. I miss not doing paperwork. Because as a caseworker, all you're doing is so much paperwork. And the one thing about being a peer is that's the one thing you're immune from is you do have to do notes, of course, but you don't have to be, you're not filling out someone's tax return for them. Although I can say I'm better at filling out someone else's tax return than I am my own.
So thank you so much for that. What I'm going to do now is I'm just going to summarize my experience working with you early on, and I'm going to share a couple of ideas just for people to think about moving forward. I'm just going to talk for about 3 minutes or so. When I started working at St. Michael's Hospital, it was very clear that we needed to have harm reduction services, harm reduction support. And unfortunately, in my fellowship, I hadn't been trained in that. I went down to the Works, which is the Toronto Public Health Agency, and they made it very clear that me just learning it wasn't going to be enough to bring in those principles. And we had to have someone a part of the clinical team. A colleague of mine who's the head of addiction, Dr. Questel, was working with TCAT, which was the agency that JP did his training with, and they've been working for a couple of years trying to figure out how to get some part-time funds to bring in a couple of peer support workers. And the first few months that JP and his colleague joined us, it was transformative. I have memories of patients that wouldn't talk to me, and then similar patients where all of a sudden they'd have small talk with JP. JP would go have a coffee with them, all these kinds of experiences. And every time I would ask JP, what do you do? You're like, I just had a conversation with him. I just brought him a coffee, and then I came back a couple of days later. I have memories of patients in the emerge that would refuse to talk to me, that were clearly unwell, that would text and talk to JP over the course of a couple of weeks. And then finally they would come to clinic and get support. I've had memories of patients that were using throughout the day, all day, and then all of a sudden they'd have gaps just through that relationship with JP. And I had memories of people that came to hospital where I believe, and I might be wrong, but I believe anecdotally, they were more likely to stay in treatment, they were more likely to consider the treatment options we were offering, and they're more likely to complete the course of care, at least from what I saw. And it was almost like magic. Like there was no amount of motivational interviewing, there was no amount of psychotherapy, there was no amount of medications I could give that would allow these people to stay and complete those courses of treatment. In that time, there's a lot of things that I've realized as well. You know, I tend to give people a lot of responsibility, and I didn't always realize how much support was required and what's a reasonable amount to delegate to which person. I also didn't fully appreciate or realize the amount of pre-coaching and debriefing required for every patient encounter. Some of these patients are quite unwell at the time that they come in. Some of the outcomes aren't good. I've had a medical training. I've worked as a psychiatrist for many years. I've developed all these strategies to deal with these complexities and my own internal transference, countertransference. These are not training the peer support workers have had. And so I think the infrastructure may have been able to have been designed a little bit better. And also, it's also hard to be the first person into an organization, the first couple of people, because we'd never had peers before who were a direct part of the clinical team. I really believe that peers are essential. What they allow us to do as healthcare providers is reconnect with that compassion and that hope that these are people and human beings. Sometimes you only see people when they're angry, when they're frustrated, when they're yelling, when they may be lying in some kind of way. But this is how people have coped for years or decades or whatever that might be. And being able to see the human underneath and being able to provide that compassionate care is a very important skill. And having people like JP on the team, it's almost just a reminder that everyone can become, and everyone was someone like JP is, and JP was as well. And we just have to figure out how to create an environment where they're more likely to get better. The second thing, having someone on the team, is that we get a better idea of what are some of the steps required for recovery, or at least to reduce the harm that the person's experiencing. And it's going to be different for each person, but having someone there to have that dialogue who will tell you that, hey, you know what, you probably shouldn't have said that way, or, it might be a little bit intimidating if you come in and bring things like that, or maybe, I'll just talk to them in the hallway, and then I'll let you know if they want to talk to you. In that time, since we started working together, I think it was 2017, 2018, I can't remember the exact year, a lot of organizations have brought in peer support. I've seen patients that also work in peer support, and I think a lot of the similar themes are there. It's transformative having them on the team. It's nice when they're remunerated properly, and it's also nice when they have the proper support to deal with these chaos, because I don't think the medical field is comfortable or was ready to deal with the amount of death that we're seeing in this patient population. And hopefully over time there'll be some kind of infrastructure to provide good support for them. I know for me, when I've had a team member who used to or who may currently inject drugs, all of a sudden we have someone on the team that speaks the language of the people we're serving, and all of a sudden the trust can develop much more quickly. A few organizations have come up with very specific rules around confidentiality, so disclosing what you can share, what you can't share, and trying to navigate that line between, are you an advocate for the patient, are you an advocate for the doc, because sometimes it can get to be a bit of a gray area. But what we really wanted to do today in this brief 15 minutes is to share with you the story of a peer who's excelled at their craft and moved on to other things, but still, for me, the role of the peer was so powerful for what the person did. And also hear a bit from a physician who tried but also struggled with how to incorporate peers into their practice effectively. And we're so excited to hear about the involvement of others, and we hope that people consider what kind of infrastructure is going to allow it to be successful. And thank you for hearing our story.